books are made up of nuts to know.
Yes.
Have you ever asked the teacher, just tell me what I need to know? And they say, well, read the book and the notes. Well, that's helpful. Well, part of what you're paying me for is to take all of that's in those books and narrow it down to this. So that if you know this, you know what everybody else knows. And soon you'll get to stuff that no one knows. You won't know everything, but hey, that's cool. So don't think you have to know everything. Because if you try to learn everything, you'll master nothing. Did you hear what I said? If you try to learn everything, you'll master nothing. And that's what students do. They just try to learn more. No, more isn't the solution. Okay? Focusing on what you really need to know and then how to apply it. That's what we're talking about. Okay? Back on page 12a. Terminology. Whenever the question says QRS depolarization, it's talking about ventricular. If it says blankety blank, 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 QRS depolarization is blank, 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 you can always narrow it down to one of two. Both of those would say what word? Ventricular. You can rule out anything that says what? Atrial. If you see QRS, you can rule out anything that says ventricular, atrial, and go with what's ventricular. However, number two, if it says P wave, that will refer to something atrial, and you can rule out anything ventricular. Unless they say a lack of a P wave. Well, I mean, that's not really talking about a P wave. All right, let's use that to answer letter B, the 6 rhythms most tested on NCLEX. Number 1, they will use this phrase, a lack of QRSs. There are no QRSs. 0. None. What do you think that's called? Asystole. That's a flat line. That's asystole. Number 2 has to be a form of what?
Atrial.
Atrial. Why does it have to be atrial?
It's P wave.
It said P wave. And when you see sawtooth, you always pick flutter. Flutter is always described as sawtooth. I always think of the movie Jaws. I saw the teeth and my heart did flutter. Sawtooth, flutter. Numbers 3 and 4, do you notice that they have the same adjective, the word chaotic? Chaotic is always the word used to describe fibrillation. Fibrillation. So what is number 3? How do you know it's atrial? And what's number 4? Ventricular fibrillation. How did you know it was ventricular? How did you know it was fibrillation? Chaos. These are the words they use. Okay? What is number 5? Some form of what? Atrial or ventricular?
Ventricular.
How do you know it's ventricular?
QRS.
QRS. And when it says bizarre, bizarre always applies to tachycardia. Bizarre is the word they use for tachycardias. Chaos is the word they use for fibrillations. Don't get that confused. Chaos is for fibrillations. Bizarre is for tachycardia. So if you put 2 and 2 together, what is number 5? Ventricular tachycardia. Do you see how this can be easy if you just know your words?
Why did they do that?
What's that?
Why did they do that? Why did they put chaotic then? Why did they do that?
Why
How would we know that?
Oh, why didn't they teach you that?
I mean, why did they put that in the HESI test? Why did they put those words in there?
They did. They did. You mean they...
I mean, yeah, why do they? They are, I mean, they're trying to mess us up?
No, actually, what they're doing is they're seeing if you know what those words mean. You see what I'm saying?
So we were supposed
Do you
to be
know
taught.
what chaos means?
Somewhere along the line, we should have been taught this.
Yes. Somewhere
And we
along the
weren't.
line,
And we weren't.
you should have been taught that chaos was fib, flutter was sawtooth, bizarre was tacky, QRS was ventricle, P wave was atrial. You see what I'm saying? You should have been taught that.
Wow.
Okay. Well, what about a periodic wide bizarre QRS? That's a PVC. Why is it ventricular? And why is it wide and bizarre? Because it's like one snapshot of a tachycardia. Right? It's just one piece of tachycardia. So, is it possible, could you call a salvo of PVCs You know, a salvo of them, a group of them in a row, a salvo of them. What else could you call it? A short run of V-tach, couldn't you? Because it's the same idea. Now let me ask you this. Do physicians care about people having PVCs? Generally speaking, no. How high a priority is a client with a PVC? If you had to prioritize 4 clients and one of them has PVCs, how high would you prioritize that guy? Low, moderate, or high? Low. All right? Now, under 3 circumstances, you could elevate that person to moderate. Not high priority, just moderate priority. And here's the list right here below. If there are more than 6 PVCs in a minute, or more than 6 PVCs in a row, or if the PVC falls on the T wave of the previous beat, that's called R on T phenomenon. If one of those is true, you elevate the priority of your PVC client to moderate. So PVCs never reach what level? High. They never reach high. The most a PVC client can reach is moderate, and that's if there's more than 6 in a row, 6 in a minute, or falling on the T wave. Otherwise, how high do you prioritize your PVC patient? Low. Isn't it true that after an MI, after a heart attack, if they're having PVCs, what do you know? Is that good or bad? That's good. So actually it means they're reperfusing. So that it doesn't raise their priority, it even lowers it, because they're doing great. So anybody ever work coronary care or telemetry? If you call physicians in the middle of the night to tell them that the patient is having PVCs, what is the most common order you will receive?
Don't ever call me again.
And how will they say that?
Hang up.
Discontinue the monitor. They'll tell you to DC the monitor. Why? Because if you don't have the monitor, you can't see the PVCs. And if you don't see the PVCs, you won't call them. So you learn real quick, you know. Don't call a doctor about PVCs unless you want to lose your monitor. Okay? All right. Lethal arrhythmias. How high a priority are these? Moderate, low, or high? These are high priority. There are 2 of them that are super high priorities. They're lethal, meaning they will kill you in 8 minutes or less. The first one is asystole. Right? If you're asystolic, you got 8 minutes, or that brain's gone. V-fib is also the lethal one. What do asystole and V-fib have in common? No cardiac output. And if you've got no cardiac output, you do not have brain perfusion. And if you don't have brain perfusion, you're dead in 8 minutes. So if they give you 4 patients and one of the patients has asystole or V-fib, how high do you prioritize that patient? They're probably number 1. Probably number 1. Letter D. One of these arrhythmias is a potentially life-threatening. It is not life-threatening. It is only potentially life-threatening, but that still makes it a fairly high priority. And that is ventricular tachycardia, V-tach. So therefore, what is the difference between V-tach and the asystole V-fibbers? V-tachers have a cardiac output. So that makes all the difference in the world. Were you ever in a code situation and they're given drugs or something and the rhythm changes? On the monitor, the rhythm changes because of something they did. What's the first question the doctor will always ask? What's that? Do you get a pulse with that? Why? What are they asking? Is there a cardiac output with that? You see? And so even if the rhythm changes to something that looks good, if there's no pulse, there's no cardiac output, it's just as bad as what was there before. Okay? All right, turn the page. Let's talk about treatment of these problems.
One
Treatment,
quick-
yes.
On that number 6 where periodic is underlined, is periodic mean PVC then?
Yes. Because it's not a continuous phenomenon. It's only occasional. Okay, let's talk about the treatment. The first two are PVCs and VTAC. They are both ventricular, correct? You see this? See my fingers? What letter do they make?
V.
A V. For ventricular, now watch what happens. For ventricular, use, what letter is that?
L.
Lidocaine. For ventricular, use lidocaine. For ventricular, use lidocaine. So I always tell people to remember that. Ventricular lidocaine, ventricular lidocaine. Now I know that lidocaine is not used in a lot of squads now in the bigger cities because they're using amiodarone. But Boards is going to talk more about lidocaine. After April 1, it would be amiodarone. Amiodarone. So I guess after April 1, I'm going to have to say, see the V for ventricular? Amiodarone. No, I'll have to get something else. Why do squads in rural areas still stock lidocaine instead of amiodarone for VTAC and VFib? I mean VTAC and PVCs. Yes, it's like 1/10 the cost and has 4 times the shelf life. So why would you buy a super expensive drug that's going to expire in 3 weeks when you won't use it that much? But if you work squad in Franklin County, you're going to use it up so fast, might as well have amiodarone. But if you work Vinton County or something like that, you good luck. Amiodarone is going to spoil before you ever use it. Okay, supraventricular arrhythmias. What's that a synonym for? Supraventriculars. Atrials. For atrial arrhythmias, use the ABCDs. Atrial starts with what letter? A. So remember the ABCDs of atrial treatment. So for ventricular, you use what? Ventricular, use lidocaine. For atrial, use the ABCDs. So what are the ABCDs? A stands for adenocard. ADENOCARD, adenocard. ADENOCARD, adenocard, which is adenosine. This is the one you have to push in less than 8 seconds. So is it a fast or slow IV push? Fast. Now, why do I bring that up? Well, here's why I bring it up. The reason why I bring it up is when you're talking about IV push, when you don't know, you go slow. You heard that? When you don't know, you go slow when you're pushing. Now, I'm worried because you go, oh, I don't know adenocard, so I'm going to what? Slow. No, this is the one you got to know. It's the super fast. You got 8 seconds. They call it slamming. Have you ever heard of that? You got to slam this drug. You got to push it in 8 seconds, and then the other nurse pushes 20 milliliters of flush right after it. So you're going wham, and they're going wham. So you got to use a big vein. You can't use one of these. You have to use what we used to call it the intern vein. Something so big an intern could hit it. So we used to use the intern vein, one of those big ones. Now the problem with this is when you slam it fast, what could they go into? Asystole. And they could go into asystole for about 30 seconds. But they'll come out of it. You just have to trust. They'll come out of it. They really will. But it's kind of scary. 30 seconds of asystole is scary. But what do? Sit there, relax. They're going to be okay. So what's the big thing you have to know with adenocard? Push it fast and don't worry about asystole. Oh, unless it's longer than 30 seconds. Okay, B. B stands for beta blockers. Beta blockers. And what do all beta blockers end in?
LOL.
LOL. Yes. They all end in LOL. LOL. Timolol, atenolol, nadolol, carvedilol, bredilol, propranolol. Those are all beta blockers. This is the best class of drugs, best named class of drugs in the universe. Every drug that is a LOL is a beta blocker, and every beta blocker is a LOL. It's great. Every drug should be that way. Okay, I always used to say, when we were in school, we used to do stupid things. You see that right there? That's baby beta. See the little curly Q? Actually, in bigger, it would look like this. Yeah, that's baby beta, and she's what? Blocked in. She can't go either way. Beta blocker. So, LOL, beta blockers. Now, beta blockers are negative INO, negative chrono, negative dromo. Negative INO, negative chrono, negative dromo. So they're like what? And so they're like Valium for your? So they'll treat A, AA, and AAA. And what are we talking about here? AAA, anti-atrial arrhythmia. Correct? So what will beta blockers have as a side effect? Headache and hypotension. Just like the calcium channel blockers. So don't make a big difference between calcium channel blockers and beta blockers, generally speaking. The only thing is that calcium channel blockers are better for people with asthma, because beta blockers broncho constrict. So people that have other diseases like COPD probably should be on a calcium channel, although a beta does all the same things and has all the same side effects. Oh, so therefore, what's the C? Calcium channel blockers. Because beta blockers and calcium channel blockers are like Valium for your heart. They're negative INO, negative chrono, negative dromo. They treat A, AA, and AAA, and they have the side effects of H and H. Both of them. The D stands for digitalis. Digoxin, Lan-oxin. You have to know these names because they will only give you one name for this drug. They'll say Lan-oxin. You're supposed to know that's digitalis. They will not give you both. If you do not know that Lan-oxin is digitalis, you don't know what everybody else knows. So know it. So what are the ABCDs of treating atrial arrhythmias? Adena, beta, calcium, dig. Adena, beta, calcium, dig. Adena, beta, calcium, dig. Adena, beta, calcium, dig. Those are the ABCDs of atrial treatment. So what do you use for ventriculars? Lidocaine. What do you use for atrials? Adena, beta, calcium, dig. The ABCDs. All right. Okay, what do you use, number 4, what do you use for VFib? It rhymes. For VFib, UD fib. For VFib, UD fib. In other words, what's defib mean? Shock 'em. And asystole, what do you use for asystole? Epinephrine and atropine. Epinephrine and atropine. In that order. What's the first one you give? Epinephrine. Then if that doesn't work, you give atropine. Now, the way I remember this is, look at the word asystole. All right? What's the first letter? A, which stands for atropine. What's the last letter? E, which stands for epinephrine, but give it reverse. So A for atropine, E for epinephrine. What I do is I always do this. Asystole, atropine, epi. And I have that, you see this visual? I sort of have this visual of it coming down, and then I just go, give it opposite. So what do you do for VFib? What do you do for VTAC and PVCs? What do you do for atrial flutter and atrial fibrillation? Adenovate calcium ditch. What do you do for asystole? Epinephrine and atropine. Very good. If you know that, you know more than what most people know about those emergency things. Okay, let's talk about chest tubes. The purpose of a chest tube is to reestablish negative pressure in the pleural space. Reestablish negative pressure in the pleural space. So the pleural space is a place where negative is good. Because don't we tend to think of negative as bad? But negative is good in your pleural space. Negative makes things stick together. Got me? Okay, what's your name? You're Shauna. Okay, Shauna and I are going to demonstrate some things. Think about it first. Shauna is the chest wall. I am the lung. Okay, she is the chest wall, I am the lung. Now, we're actually three-dimensional, although we're only showing you a one-dimensional picture. There's actually, you know what I'm saying? Everybody get the cross-section here we're looking at? Okay, so she's the what? I'm the, okay, what's out here? Atmospheric air, right. So this is skin and bones and muscles, right? And then I'm a what? Lung, and what's in here?
Air.
The what? The alveolus. I can't make three of them at once. I know you're used to a picture with three, but I can't do that. Okay, that's the alveolus. Are you getting the picture? Now, on the inside of the
Chest wall.
is a lining called the parietal pleura. So this is the what? Parietal pleura. It lines the inside of the chest wall. Okay, now on the outside of me, there's another lining. What's this called? Visceral pleura, and it lines the outside of the lung. Between the
Chest wall.
parietal pleura and the
Visceral.
pleura is the pleural space. So we got this space here called the what? Pleural space. Now, what kind of pressure should be in there?
Negative.
Now, what does negative pressure do to things? Pull them together or push them apart? Negative. Pull together like a vacuum. Positive pressure pushes things away. So, what are we going to do here? If there's negative pressure in here, what's going to happen? We're stuck together. Because there's what? Negative pressure in the pleural space. Now, how is this going to work? Okay, we're going to breathe in. Now, when we breathe in, the chest wall expands outward. Okay, so we're going to take a few steps out that way. So now we're going to breathe in, and you watch the air going into the what? Alveolus. Okay, here's the air. Now, ready? Let's breathe in. Oh, what happened to the air? Came in. Now let's breathe out. Did you see? Now let's breathe in again. Let's breathe out again. All right, now there's good what? Air exchange because there's
Negative pressure.
in the. Okay, now take your gun and shoot us. She's got a silencer on. Bang! Okay, a bullet comes. Now what has entered the pleural space? Air and blood creating what? Positive pressure, which is going to do what to us? Push us apart. Okay, now I want you. So we're no longer what? Stuck together. She has muscles. What don't I have? Muscles. She does the work of breathing. I just hang along for the ride. Now, what we're going to do is, now that there's positive pressure in here, I want Shauna to breathe in and then breathe out. And I want you to watch what happens to the air exchange. Okay, breathe in. Breathe out. Breathe in. Breathe out. What's happening? She's doing a lot of what? Work. But there's no air exchange because there's positive pressure in the. Okay, now take that chest tube you have there in your hand. Okay, now pretend you're sticking it in here. Okay? Now give me some suction. Okay, now what did we just do? Re-established negative pressure in the pleural space. So now she can breathe in, breathe out, breathe in. Now we heal, and what does she do? Pulls out the tube, and we're good to go. Thank you. Very good. Very good. So she's going to sit in the back from now on. So what's the purpose of a chest tube? Reestablish negative pressure in the pleural space so that the lung expands when the chest wall moves. Is that making sense? Why you need that tube in there? Okay. Now when you get a chest tube question, look at the reason for which it was placed. Letter A there, number 1, says in a pneumothorax, the chest tube removes what? Air. Pneumo means air. So in a pneumothorax, what created the positive pressure? Air. So I've got to put a chest tube in to remove air so I can reestablish the negative pressure. Okay, but in a hemothorax, the chest tube removes blood, because what's causing the positive pressure? Blood, and I got to remove it to reestablish the negative pressure. And in a pneumohemothorax, what's in the pleural space? Air and blood, and I must remove both air and blood to reestablish the negative pressure in the pleural space. So if Boards gives you a question and says that you have a patient with with chest tubes in for a hemothorax, what would you report to nurse LPNs or doctor RNs? What would you report to the nurse or the doctor? Number 1, the chest tube is not bubbling. 2, the chest tube drained 800 ml in first 10 hours. The chest tube is not draining. The chest tube is intermittently bubbling. Well, you have to say to yourself, what do I expect from a hemo? What does a hemo chest tube put in for a hemothorax? What's it supposed to do? Drain what? Blood. So, which one of these says it is not doing what it is supposed to do? Number 3. So which one would you report to the nurse or the physician? Number 3. Because it is not doing what it is supposed to do. Do you see that? See what I'm saying? Well, what if I said this? A pneumothorax. What would you report to the physician? Well, you could have 2 of them. What would they be? 1 or 2. Right? What's wrong with 1? It needs to bubble. It's not doing what it's supposed to do. What's wrong with 2? It's doing something it's not supposed to do. And in that case, it would be a hard, do you see what I'm saying? It would be a hard one to do. But the point is that, do you see how it definitely wasn't number 3. Do you see when I changed? Did you see that when I changed from a hemo to a pneumo, what was the right answer is no longer even an option for the right answer. So if you're going to get chest tube questions correct, what must you pay particular attention to? The disease for which it was placed. And that will tell you what you should expect. Does that make sense? That you're going to have to watch that? Otherwise, you wouldn't get it right. Okay, the other thing you have to pay attention to is letter B, the location of the tubes. The location of the tubes. And the 2 locations are apical, A-P-I-C-A-L, and basilar, B-A-S-I-L-A-R. Apical, number 1 is apical, A-P-I-C-A-L. And number 2 is basilar, B-A-S-I-L-A-R. Apical and basilar. Now, apical means the chest tube's way up high, And if you put a chest tube way up high, what are you going to remove? Air, because air rises. So apicals remove air. Basalars are at the bottom of the lungs, so they